Good afternoon and happy viewing, everyone. I'm Dr. Michael Reinhardt, Director of the Brooklyn Initiative to Develop Geriatrics Education, or BRIDGE for short. And it's my pleasure to welcome you today for this session on dementia, a cardiovascular disorder in late life, an important question and topic that affects the care and quality of life for many of our older patients. This lecture is one of a series brought to you in support of the activities of the BRIDGE program, as well as our new advanced certificate program in public health geriatrics in our School of Public Health. This talk will also be used to create an online learning module for continuing education for all of Brooklyn's providers, students, and trainees. The Brooklyn Initiative to Develop Geriatrics Education is funded by the Health Resources and Services Administration as part of their Geriatric Workforce Enhancement Program. The BRIDGE program was developed in partnership between 4 of the colleges and schools at SUNY Downstate Health Sciences University, including the College of Medicine, College of Nursing, School of Public Health, and the School of Health Professions. This interprofessional partnership of our colleges and schools is complemented by outstanding partners in the community, including the New York City Health and Hospitals, Kings County, Brownsville Multi-Service Family Health Center, and the Fort Greene Council and its network of 13 senior centers throughout Brooklyn. The overall goal of the BRIDGE program is to provide the education and support needed for Brooklyn to become an age and dementia-friendly place for our senior neighbors to obtain their health care. And it is our pleasure today to welcome Dr. Jason Lazar to speak on this important topic. Dr. Lazar is Vice Dean of Education in the College of Medicine at SUNY Downstate Health Sciences University, Chair of the Department of Medical Education, Director of Non-Invasive Cardiology, and the former Director of the Cardiology Fellowship Training Program at SUNY Downstate. He is a distinguished teaching professor of SUNY, as well as Professor of Medicine, Neurology, Public Health, Molecular and Cell Biology. Dr. Lazar received his medical degree from the SUNY Upstate Medical Center at Syracuse and completed his postgraduate training at the University of Pittsburgh Medical Center in Pennsylvania. He received his MPH from the Columbia University School of Public Health. His research interests include brain-heart interactions, arterial stiffness, the epidemiology of coronary heart disease in women and in high-risk populations, and in health disparities. He is a member of the editorial board of multiple journals and serves as a reviewer for numerous peer-reviewed journals. He is widely published with more than 200 peer-reviewed manuscripts and has embarked upon several international collaborations, including medical missions to various countries. He is a fellow of the American College of Physicians, the American College of Cardiology, the American Heart Association, and the American College of Chest Physicians. He has previously served as the chair of Cardiovascular Network and New York State representative of the Governor's Council of the American College of Chest Physicians and on the American Society of Echocardiography Research Committee. He has received multiple accolades for academia, including the SUNY Chancellor's Award for Excellence in Scholarship and Creative Activities. He currently serves as the co-principal investigator of a multi-center R01 grant investigating mechanism of left ventricular dysfunction and HIV infection. Over the past decade, Dr. Lazar has been awarded 4 different New York State Department of Health Empire Clinical Research Investigator Program training grants, and now serves as SUNY Downstate's ECRIP Committee Chair and liaison to the Department of Health. Thank you, Dr. Lazar, and we hope you enjoy this important talk today.
Good afternoon. I'm Jason Lazar, and it's a pleasure to present on the topic of cardiovascular disorders in late life. I'm grateful to be part of the Brooklyn Initiative to Develop Geriatrics Education, the HRSA Geriatrics Workforce Enhancement Program. I don't have financial disclosures. My only disclosure is that I am not a neurologist. Let's start off with a case. A 76-year-old woman presents, and she's been widowed for 12 years, has a history of hypertension for 25 years, and is treated with a combo pill of valsartan and hydrochlorothiazide. She began some unintentional weight loss 5 years ago and progressive memory loss for perhaps 3 years. Her daughter reports that she neglected to pay her property taxes for the past 2 years, an important social history. Blood pressure was 132/64, pulse 76 and regular. Her physical exam was otherwise normal. On EKG, she had sinus rhythm, some left axis deviation, and nonspecific ST segment and T wave changes. Her labs were unremarkable. Notably, she had normal thyroid function tests with a normal TSH, and her LDL was 134 milligrams per deciliter. So how should this patient be treated? She obviously has dementia, a common condition, especially late in life, characterized by memory impairment, as well as impairment in other cognitive domains. Dementia is almost universally progressive, associated with impairment in functional status, and is associated with considerable morbidity and mortality. Moreover, it's progressive without cure. So, the topic of today's talk is dementia, a cardiovascular disorder in late life? The objectives of today's discussion will be to make the case that dementia should be considered a vascular disease, irrespective of the type, to understand which cardiovascular risk factors contribute to dementia and the temporal relationship that exists between risk factor appearance and cognitive dysfunction, and to identify potential opportunities for delaying the onset or slowing the progression of cognitive dysfunction. There are various types of dementia, and I make my disclosure again, I am not a neurologist. There's Alzheimer's disease, which accounts for 60% of all cases. Vascular dementia, another 20%. And this is the most common form of dementia in Asia. It usually is observed in a stepwise progression with focal cognitive deficits or impaired executive function, but memory impairment is not necessarily the case. And furthermore, vascular dementia is expected to be the most commonest form throughout the world in years to come. There's a mixed type of dementia. There's Lewy body dementia, which comprises 10% of all cases, and 10%, and this is commonly associated with Parkinson's syndromes, and others as well, comprising another 10%, including frontal lobe dementia, which involves executive dysfunction, poor planning, and impaired judgment. Recent memory is actually usually preserved. There's abulia, disinhibition, sometimes depression, and other forms in this miscellaneous group, including alcohol and corticobasilar. Alzheimer's disease occurs on a progression, as do all forms of dementia. And it's important to differentiate this from the mild degree of cognitive impairment that's seen in normal aging. This gives us a large window of opportunity to try to intervene and to prevent the more rapidly progressive cognitive impairment seen as a prodrome to overt dementia. And we're all aware of the rising rates of dementia, notably Alzheimer's in the United States. Currently, there are almost 6 million persons with Alzheimer's dementia, and this is roughly 2/3 of the total cases. And after age 65, the risk doubles nearly every 5 years. After age 85, the risk is nearly 1 in 3. And Alzheimer's disease, the most common form of dementia, is universally viewed as a neurodegenerative disorder. It involves amyloid and tau deposition. Regarding amyloid, beta amyloid is a type of glycoprotein that is abnormally concentrated in the brains of patients with Alzheimer's disease. Amyloid aggregates into clumps known as plaques, which are supposedly toxic. They cause inflammation, oxidation, and injury to brain cells that is irreversible. Secretases and presenilins are enzymes that are involved in producing beta amyloid, and it's unclear whether beta amyloid is a cause or a bystander. With regard to tau, this is a protein that forms microtubules which transport nutrients into cells. And when these tau proteins get hyperphosphorylated, they become neurofibrillary tangles, which go on to further damage cells. So we've learned a lot about the neuropathology of Alzheimer's disease since Alzheimer himself described the first case of a 57-year-old man back in 1907.